Hi, everyone. My name is Daniel Scher from the Medical University of Graz. I'm an electrophysiologist at this center, and together with my colleague Martin Rauber, who is currently a fellow with us and who is originally from the University Medical Center of Ljubljana, Slovenia, we will present some thoughts on the effective refractory period, or ERP. Measuring and applying effective refractory period represents the basis of EP testing. Now, of course, the question arises, what is the effective refractory period and which types of refractory periods do we know?
During cardiac cycle, once the action potential is initiated, the depolarized cardiomyocyte first becomes inexcitable to another stimulation, regardless of its strength. We call this an absolute refractory period. Absolute refractory period is followed by a period in which membrane has repolarized to a certain degree, so that stimulus can depolarize local cells but cannot cause propagation of the action potential. The sum of these two periods is called effective refractory period, or ERP. After further repolarization, ERP is followed by a relative refractory period, during which only a larger than normal stimulus can result in activation of cardiomyocyte and lead to a propagation of the action potential. In EP testing, we primarily focus on measuring ERP. By definition, ERP is measured using program stimulation, which means a train of pacing beats followed by a coupling premature extra stimulus. ERP is defined as the longest premature coupling interval S1, S2, that results in failure of propagation of the pacing impulse through a tissue. ERP can be evaluated also during incremental pacing and is defined as the longest coupling interval that does not achieve a capture. ERP measured with program stimulation is usually longer than with incremental pacing. Why is that? Because refractoriness is directly related to the basic drive cycle length due to rate-related shortening of the action potential duration. It is important that ERP is measured at specific sites. Measurements of atrial and ventricular ERP are taken at the sites of stimulation. Measurements of AV node ERP and His-Purkinje system ERP are taken from responses in the His bundle electrogram and additional assessments of ECG. Increases in sympathetic tone significantly shorten AV node ERP. It also shortens ventricular ERP, but on the other hand, atrial ERP gets usually slightly prolonged. Parasympathetic tone, of course, has the opposite effect. During an EP study, we assess both ventricular ERP as seen here and atrial ERP as seen here with incremental pacing.
So we normally follow that by assessment of ventricular atrial conduction, as seen here, in which only atrial or ventricular pacing intervals longer than ventricular ERPs that we have established before can be used, as shown in this example. In the next step, we can assess atrioventricular conduction, in which case only atrial intervals, pacing intervals, longer than ERP that we have established before can be used. And again, you see an example here. With that, we assess the ERP of the AV node and ERP of its extensions. And in electrophysiology, we call that fast and slow pathways, which can be part of the antegrade and retrograde limbs of AVRNRT.
In patients with accessory pathways, we assess their antegrade and retrograde conduction properties and their ERPs, which in case of asymptomatic WPW patients can be used to assess risk and facilitate decision for ablation. In this patient, you can see that we tested retrograde conduction during programmed ventricular stimulation. In this image, you can see eccentric activation sequence on the CS catheter, which is typical for septal and left-sided accessory pathways. With further shortening of the paced coupling interval, accessory pathway ERP was reached, and the paced ventricular beat did not conduct retrogradely to the atrium. And you can see that the next sinus beat has normal concentric CS activation. We can also assess infranodal conduction system ERP with programmed or incremental conduction system pacing, as you can see on this image. With incremental parahesian pacing, we first captured His bundle as represented with narrow paced QRSs. With further shortening of the paced cycle length, we reached His ERP with the consequence of capturing septal ventricle, which is represented by sudden widening of the QRS. Similarly, you can test conduction system ERP also with programmed stimulation, as in this case where we recorded programmed parahesian pacing. In this image, all paced beats are His bundle capture beats. With further shortening of the paced coupling interval, His ERP was reached, and as a consequence, septal ventricular myocardium was captured. Both of these techniques are not only used in EP-lab, but can also be used during conduction system device implantation to assess and guide lead placement. All in all, we think assessment of ERP of different cardiac tissues enables us to diagnose and treat the underlying arrhythmias.
So, dear friends, dear colleagues, this was a little bit about the ERP in a nutshell. It's one of the most important concepts in electrophysiology, and the maneuvers we showed you and the concepts we demonstrated are used in every EP lab in the world, I would say, on every given day. With that, our small lecture finishes. Keep on pacing and keep on ablating. Thank you very much.
Thank you.